Thank you, Dr. Garg and his team for this invite, and respected teachers in the audience and your friends. So autoimmune encephalitis, as one would say, that we all have an innate immune system which is there in our body which helps us to fight the infection. But that in certain conditions, what happens is the immune system is very vulnerable, and I should say that the immune system reverses back, like any friend sometimes reverses back and starts attacking oneself. And that's when autoimmune encephalitis, so what was there to protect us, starts devastating the particular individual. We know in certain immune conditions, which is very common, like in MS, ADEM, MOG, and now we are talking about the autoimmune encephalitis. So it is a group of non-infectious immune-mediated inflammatory disorder of the brain, and which involves the cortical and the deep gray matter with or without involvement of the white matter, meninges, or spinal cord. It has become very common. Or probably it was common earlier, but now we are recognizing it more and more. So how does it really work? So now this is an antibody-mediated encephalitis. Now we have two types of antibody-mediated encephalitis. One is it is associated with the cell surface antigen. The other one is associated with the intracellular antigen. So why this is important for us to know that? A cell surface antigen, it is against the neuronal surface antigens. They can reach their target and they are pathogenic. And they are very treatment responsive. So I have a particular individual with an NMDA receptor encephalitis. I know that if I instituted immunotherapy, I'll get a good response out of this particular individual. And if treated properly and in time, then they have a lesser propensity to go on to become an autoimmune epilepsy. On the other hand, which are associated with an intracellular antigen, they're more with a presence of an underlying cancer, which might be detected then or might be detected at a later point of time. They cannot reach the target and they're not pathogenic. They are morely T cells and they are treatment resistant, and they have a progressive and a devastating course, and then they have a high propensity to develop an autoimmune epilepsy as well. So this is a timeline of the discovery of various antibodies which are there. You can see that it is growing in number. Surprisingly, anti-GAD was discovered quite way back in 1988 with a person with stiff person syndrome, but its association with autoimmune encephalitis was not known until 2008, and that's the time where 2008 we started knowing about the autoimmune encephalitis as well. So you can see that the now ever-ending. That's the graph which shows that while we were way back in the 1995 to 2025, we had a spectrum of illness which was almost comparable, autoimmune as well as infective. But now we can see that the autoimmune is quite superseding the infective panel as well. Now, when do you suspect? We are clinicians and we should know when we should suspect it so that we can get a hang on which antibody, where, how to send the investigations. A detailed history and examination absolutely is most important and foremost, as we all know. The immune reaction often results in an acute or a subacute condition, which usually is as a duration of less than 3 months. We might have a chronic presentation in some particular group of patients, like we know that it is in LG1 or in Casper2, and especially in DPPX, in elderly with weight loss, diarrhea, which can be going on little more protracted in these patients. GAD65, we know that it can be a little more protracted. It can be, in fact, a presentation of a chronic epilepsy when you're not having any other factor there. Hyperacute presentation is never seen usually, but then one should be very cautious. The patient may present as a status epilepticus in the emergency, and it may look like a hyperacute presentation, but then when you take a clear-cut history, there's always a background history of a cognitive or a psychiatry or a movement disorder, but his presentation became like a status epilepticus, let us say as a GABA receptor and patient. So one needs to have a history. Presentation can be like a hyperacute, but then there's always a background history of other symptoms. Recurrent course, yes, may point towards an autoimmune etiology, but unlike the typical relapsing and remitting that we see in multiple sclerosis, autoimmune encephalitis relapses are rare, and it is usually, if it was not as effectively and as fast treated when the patient should have been diagnosed, or the patient's treatment was very quickly withdrawn because the patient developed a good remission from the disease. So otherwise it is. A monophasic illness is most common in idiopathic autoimmune encephalitis, while a progressive course may be seen in more paraneoplastic. So, we are talking about the idiopathic where we say the neural and the cell surface. So, a protracted going on and getting on to a disabling course is more common in the paraneoplastic part of the autoimmune encephalitis until and unless one could identify the underlying cancer and could treat them. Still going further with the clinical itself, one would have a history of fever and constitutional symptoms when the patient comes in with an autoimmune encephalitis. HSV encephalitis, all of us know that a propensity to go on to develop an NMD receptor encephalitis at a later point of time because of an antibody, as I said, tends to develop to its own patient's body. A classical syndrome which is seen in DPPX, that is a dipeptyl peptidase-like protein, where there is a classical weight loss, an elderly man, diarrhea, all the tests done, endoscopies, scopies, all tubes process done, and we are not able to find out. One should always be wary. The patient does land up in a neurological department because the patient develops all the other symptoms, malaise, asthenia, cognitive symptoms, and then one should be considering that. Clinical phenotype. Usually, they are a club of these. There is a subacute and a rapid progression. Patient has dementia, encephalopathy, cognitive, psychiatric features. We'll just touch up later. Seizures in all forms, focal, generalized, status epilepticus, fires. Multifocal. The patient can be having CNS, PNS. We know that patients have stiff person syndrome, Morvan syndrome, peripheral excitability, and neuromuscular junction abnormality. So if you have all of these features, initially if all of these features were there, one considered syphilis, tuberculosis, now we consider autoimmune. So all of these features which are not clubbing into any other strict pattern of another disease, one needs to consider that. Now, when do you suspect? Patient with a known cancer, obviously one would always be wanting to, or patient who is at a high risk, and a person who has been smoking packs of cigarette, pack years are very high, or a patient who has got unintentional weight loss, has several constitutional symptoms. One would be, you may not, even on screening you may not find, but you may want to consider that. With a personal and family history, of course, with an autoimmune disorder, a preceding viral infection, as we just touched on. Another point, we should also, the patient had a past history of a herpes simplex encephalitis and relapses with the disease. One should want to consider an autoimmune NMD receptor encephalitis in that particular patient. More importantly now, because the cancer treatment is taking a step forward, and we know that there are certain medications like immune modulating therapies, tumor necrosis factor alpha inhibitors, and more importantly, in the late cancers, patients have this immune checkpoint inhibitors. One should always look at those medications because they are very prone to develop a paraneoplastic encephalitis in patients with advanced disease on medication rather than from the paraneoplastic encephalitis per se. Again, clinically, because we are clinicians, so touching on certain factors which are very important, parasomnias, we all know that Iglon, particularly in a patient, he has got parasomnias, has got gait abnormalities, also has got bulbar features, cannot swallow. So these symptoms actually are very, very common, and as neurologists are getting to see these more often, I feel that some of the students feel that they have this illness as well. So one should be very wary because some people may have sleep disturbances, little fatigue, difficulty in swallowing. Everything is getting attributed. So an index of suspicion should be there, but then not an erroneous index of suspicion. Narcolepsy and cataplexy, one should consider a paraneoplastic MAT2 and ecopyrin, obviously. Insomnia, Morvans and Casper2. Laryngospasm, ANA2 and Anti-RI. Hearing loss, again, that's another different form. It's a Kelch-11, which is very rare, but it is described. But then one should be very, as we all know, that when there is a hearing loss, one should have other differentials very quickly in your box, which is the Suzac, vasculitis, mitochondrial, and optic neuritis. Visual deficits, patient presenting with a very early, with a syndrome of visual disturbances, one should consider the CRMP, retinopathy, or optic neuritis. That's another demyelinating form altogether. So now how do you classify? There's so many of them, so many. How do I do them? So I just put you on 3 slides now. One we can do as an anatomical classification, depending upon where the patient's symptoms are. So let us go through them. That is a limbic, that is a cortical and subcortical, striatal, diencephalic, brainstem, cerebellar, encephalomyelitis, meningoencephalitis combined. This helps us because we know that there is a classical symptom which comes with the limbic. There is a classical symptom which comes with the brainstem, diencephalic. The patient is sleepy in diencephalic. The patient is psychiatric, and patient has a lot of seizures in limbic encephalitis. Striatal is more of a stiff person-like syndrome. So it's very helpful for us to know. And if we know that anatomical localization, it helps us to more so change over to what are the antibodies which are usually seen in these. So putting here certain pictures, you can see this is the limbic encephalitis. You can see this is the cortical and the subcortical encephalitis, and the classical bilateral striatal. You can see the very here one would always want to put in a vernicase there at this point of time, or there's Whipple's, which is in a diencephalic pattern. But then in a classical presentation, you would always be putting that. Then you have the brainstem encephalitis, the Bickerstaff encephalitis, which is, and the meningoencephalitis, you can see. So depending upon the pattern of the MRI or the pattern of the clinical presentation where you want to anatomically localize, you can do one classification. Or you may want to do a serological classification where there is an antibodies to intracellular antigens, or the first slide that we saw, either to the surface antigens or to the intracellular antigens. All of us know that sometimes, or most of the times, we have a spectrum of which is a classical autoimmune encephalitis fitting into the anatomical, the clear prodrome, the clear progression of the disease, but then the antibodies come negative. So there is an antibody negative encephalitis as well. So this is a graph that shows the intracellular antigens and the surface antigens here. So one are the onconeural and these are the surface. So the GAD65 here, so I've just put off these circles here, that LGI1 is the one which is very commonly, LGI1 and Casper, in fact, both of them can be detected in the serum as well. Rest of them need a paired CSF and serum. GFAP is a cytoplasmic antigen which is associated with an intermediate filament. They are relevant in patient with the perivascular radial enhancement in particular features. Again, we need to connect the clinical as well as the radiological. GAD65 antibodies, usually we don't need a titer for any, but then GAD65 can be there in a low titer in a particular individual, and we need that in low titers. They are not very relevant to the clinical scenario. We need to have increased titers or increasing titers, so you need to check on those patients. And so these are this is how we can serologically classify them. There's another way of classification is etiological classification, whether it's idiopathic, as we said, whether it is a paraneoplastic, or I feel it's a post-infectious, or it is a nitrogenic, as we just mentioned, in the late cancer stage, if there is an immune checkpoint. So this again helps us to make. So there's an anatomical, there is a serological, and then there is a etiological classification. So now we go to the clinical clues. With all of these classification, it is very, very difficult for me sitting in the emergency that which antibody I should send. Particularly, patient has got all the investigations done. There are logistic issues if the patient doesn't have an insurance. We all understand that immune panel is extremely expensive, and then we are going to tell them that we're going to do a serum as well as CSF. Most of our patients are not insured, and then we need to know that particular panel. Having said that, it is very, very, unless you are very, very sure that the patient has got an NMDA, it is always important to send the panel of the routine panel rather than sending one antibody, unless you are very, very sure in the clinical spectrum. So here, just highlighting some of the, if the patient has psychosis, NMDA, AMPA, and GABA. So psychosis, if it is a child or an adult. In adult, it is more of a, in an NMDA, it is more of a psychiatric features than a motor. If it is in a child, it is more of a motor than a psychiatric features. And in we see in classical, in patients who are in the ICU, who are intubated, they will have a lot of orofacial in an NMDA. So if you are going next to the patient, so it may look like a non-convulsive, but then you need to have an EEG done on the patient to document that it is a motor, it is a movement disorder rather than a seizure itself. Then we have dystonia and chorea. Again, you see that it is a movement disorder related. It is NMDA receptor. Hypereplexia, you know that is glycine. Again, we take you here to the stiff person syndrome or exaggerate. There's a startle response that we see in patients with GAD65. This is more common in patients with stiff person syndrome and glycine receptor. That is, we see it in patients with progressive encephalitis with rigid person and myoclonus. So they will be very stiff. They will continue to have these myoclonic jerks, and it is an encephalitic process. So there we will go up to GAD65 and glycine receptors. So you know that it is a stiff person, there is a myoclonus, there is an encephalitis. So you move on to that. Obviously, a new onset diabetic, you find that you also have the patient might have received steroids. Most of them tend to get received steroid if the patient has got a progressive course. So apart from that, you have your systems to know that whether it is induced high sugars or the patient has been having a sugars for a longer period of time. Classical LGI-1, if you will also see the score in the autoimmune epilepsy, LGI-1 score gets 3 because it's a very classical facio-brachial dystonic seizures going on for a long time, undiagnosed because it looks like a psychiatric behavior of the patient, very short-lived. So this should be considered and should be given very due importance. Then they have the other spectrum, as we already said, the DPPX, elderly man, weight loss, diarrhea. Apart from that, he has a startle, delirium. That's GI hyperexcitability in these patients. Then we have the cerebralitis. We all of us know that the paraneoplastic panel of disease which comes with ANA has. So that's the clinical finding, how you may, either it is cognitive, it is seizure related, it is movement disorder related, or it is a mixture of them, or it is with constitutional symptoms in an elderly person. We can. So next we go to the imaging. We have more or less got a fair idea of which system of the patient is involved, and so it may be normal in some of the patient and early in the course of disease. So probably an interval scan may be required in these patients. T2 and flare are restricted to one or both medial temporal lobes. We can see in this, and we have shown in that it can be according to the anatomical classification. All of those can be involved. Or it could be multifocal T2 flare in the gray matter with that is very compatible with demyelination, or in a GABA A receptor is where that. LGI-1, basal ganglionic abnormalities. So patient has got a FG facio-brachial and a characteristic basal ganglia abnormalities. GAD65, patient with a chronic epilepsy. There is no other underlying feature that is being prominent there, and one wants to send a GAD65 for that particular individual. All of us know fires and NORS presenting later on in the course may produce a progressive medial temporal atrophy, which might not be related to an autoimmune encephalitis at all. What is the role of EEG in these patients? Some of the patients might not have anything, but there might be just some non-specific EEG sign in that. But very important classical NMDA in NMDA receptor encephalitis, which is seen in almost 30% of patients, is the extreme delta brush. You can see that this distinct is by a there is a rhythmic delta activity with a superimposed beta activity which is riding over it, and it is most commonly seen in the severely affected, might not be seen in the less affected patients. And there could be a frontally emphasized delta rhythm as well in these patients, with overlaid with beta activity that gives a generalized rhythmic delta activity. This could be a distinguishing feature in this particular type, and it plays a role in this. Also, it plays a role in patients with movement disorders, whether it is a seizure, whether we should be going aggressive in the seizure management, or it is a non-epileptic attack disorder, or it is a movement disorder which is mimicking like that. So it helps us in differentiating between the behavioral symptoms. The patient is in a non-convulsive status epilepticus. All of those factors also it helps us. Now, there is a diagnostic criteria which is available here by Gross et al., which has been validated. There's another paper in 2023 as well. This is a probable diagnosis. So you can see it is more clinical. It is not using a marker. It is not using a antibody testing there. So what it says, subacute course. It is around 3 months. It could be cognitive decline or it could be psychiatric symptoms with at least one of the following: a new focal CNS finding, or seizures which are not explained by a previously known seizure disorder, and a CSF pleocytosis and an MRI suggestive encephalitis, and rule out all the other differentials. And definitus, a subacute onset, again with the working memory deficit, psychiatric, which are involvement of the limbic system. There is a classical T2 weighted flare inversion recovery in the middle temporal lobe, and at least one of the following where there is a CSF pleocytosis and EEG with epileptic or slow wave involving the temporal lobes, and then again reasonable exclusion of an alternative cause. Having with the clinical features, with the MRI and with the EEG and with the antibody testing, which is not included in the clinical diagnosis of the autoimmune encephalitis, we need to do a search for cancer. If you are sure that it is an elderly man and you need to go through these, depending upon the age of the patient. If it is a young girl, whether you want to go with a CT abdomen, no, you might want to go with a pelvic MRI. If it's an young male, you want to go with the testicular ultrasound, and in a female, you want to go with a mammogram and a breast MRI. If the patient or none of them are being conclusive, then would you want, with good index of suspicion, would you want to put the patient for a whole body FDG PET scan? In a particular patient, let us say if patient is presented with the cerebellitis, there is an ANA, we are suspecting an ANA plus antibody. So you feel that this FDG PET has been inconclusive, but you still feel that the high index, probably there you can give reasonable doubt and have a FDG PET probably after 6 months again. When do you do an antibody testing? It's very important for us to know. Just a couple of slides, please. So test if there is a reasonable suspicion. Send before the treatment. Test serum and CSF except for LGI1 and Casper, where you can do a serum. Test a panel of antibodies rather than one. Older generation techniques have a risk of false positive. So see the lab, whether it is a research lab and they have a standardized measurement. A negative test does not include an autoimmune encephalitis. Serial testing is generally not a useful biomarker. So this I put on the slide, and one can just see for reasons of time that faciobrachial is LGI, opsoclonus, myoclonus is ANA, Morvans is Casper2, limbic encephalitis are multiple antibodies where we have a confusion. ADEM is MOG and EQUA. Progressive encephalomyelitis, that is a PERM, which I said, GAD65 and glycina. Paraneoplastic, again, there are multiple others, but the ANA and PCA. Psychiatric encephalitis, young woman, it is a NMDA receptor. You need to move out with the differentials. Infective cost, CJD can present like that. Clippers can present like that. Mock can present in that way. So one needs, and again, I always feel that it is better to have the anatomical classification and then try to come out with a differential diagnosis. I will stop here. Thank you very much.